Greetings everyone once again and welcome to the 121st session of the online Optom learning series. And today we have with us Dr. Langis Michaud. He graduated from the School of Optometry at the University of Montreal, Canada in 1986 and then went ahead to finish his Master's in Science in 1998. Since 2001, he is working as a full-time professor, and very recently in 2020, he was appointed as the Dean of School of Optometry. He is a diplomate of the American Academy of Optometry and holds a couple of fellowships in the fields of contact lenses. To be specific, he is a fellow of the British Contact Lens Association, a fellow of the Scleral Lens Education Society, and he is also a fellow of the European Academy of Optometry. He has been publishing extensively in the areas of specialty contact lenses in peer-reviewed journals and has been invited speaker around the globe on the topics of contact lenses and specialty lenses. He is also an editorial board member of the Journal of Contact Lens Research and Science. And today, Prof is going to talk to us about keratoconus. What are the contact lens options available? What's the new in and out of keratoconus management? And he'll take us through the journey on fitting lenses for these patients with corneal ectasia and keratoconus in more precise way. So welcome, Dr. Langis, onto our platform. And let me just leave the screen time to you now.
Good. Thank you very much. It's an honor for me to participate in that meeting, in that forum. Welcome to everybody, and we will share the experience that we got here in Montreal, fitting irregular cornea patients. I know that around the world, the prevalence of keratoconus and irregular cornea may be variable. Some countries affected more than others, but obviously it affects, roughly speaking, 1 out of 1,000 patients. Recent data from a research center in Europe. So it's a lot. It's a lot of patients, and diagnosis is the key, and certainly the to improve their fitting and their journey is certainly better. So here is my disclosures. Nothing really to declare, and no conflict of interest so far with the subjects and topics discussed here. So when I mentioned that the diagnosis is crucial, obviously we rely on corneal topography. You can have suspicion of a keratoconus, and I see patients younger and younger developing keratoconus. Habitually, it started around 19, 20 years old. Now it's quite frequent that we see patients at 16, 15 years old showing keratoconus pattern and keratoconus profiles. So if you have a patient where astigmatism is evolving and or the axis of the astigmatism is changing a lot between 2 visits, you begin to suspect keratoconus. If the vision is dropping every 3 months and patient is complaining that no glasses is really reliable, then it may be another signal to look for keratoconus. And your most valuable tool in your practice is the retinoscope. The retinoscope will help you to determine with the Sizer's reflex or the irregular reflex in the cornea. You can also look, through dilated pupil with the red-orange reflex, and you will see sometimes the profile of the cone against the background of the red-orange reflection of the retina. So there are several ways, if you don't have a topographer, to evaluate that. The regular keratometer may catch it, but it's very limited area of the cornea. So it's not really precise. Topography is the standard of care. And if you have access to a topographer, it's certainly the best way to do it on every patient entering into your practice, because you will detect those patients. Even the subtle one, if you look at the bottom images here, these are frost keratoconus. They are not impacting vision so far because they are not evolved enough to reach the visual axis, but they are still present, and we now have treatments that can prevent evolution of the cone. This is why it's very important to detect and to screen them in a timely manner. And don't forget that after laser surgery, it may be very possible to have also the presence of a cone, a subtle cone that was not detected prior to refractive surgery, and few months, few years later, then it shows up. So it may be very possible, and that's part of my practice here to see these patients. And when you diagnose the keratoconus, you have to decide what to do with him or with her. So every cone is unique, right? It's between two eyes. It's not symmetrical. It's not mirror. Habitually, one is more advanced compared to the other ones. The vision is more affected on one side compared to the other one. So it's a very case by case approach. The first thing to consider is the age of the subject, and we'll see why. Because the corneal cross-linking, the cornea, in fact, will cross-link itself after the age of 40 years old. So if you have a patient at 38 showing up and you just, diagnose the keratoconus, most of the evolution is over and was done in the past. So it's very rare to have, significant evolution after 40 years old. Just like your joint and your knees and your elbows, that are becoming stiffer with time, the cornea becomes stiffer because the cornea is made with collagen fibrils, and these fibrils just make more links between them, so the tissue becomes stiffer. And cone comes from the fact that, the cornea become kind of soft in certain areas genetically, and because of exposure to free radicals, and then the intraocular pressure push against the cornea and creates this bulging or deformation. Obviously, it evolves over time. So, but after 40 years old, evolution is not really there. But before 40 years old, and especially under the age of 30, it's crucial to consider corneal cross-linking as the first treatment for this condition, because this is the only way we have to halt the progression and to alleviate negative outcome on the long term. After that, we will consider the type, the shape, and the power of the keratoconus. So obviously, the more advanced conus will be fitted differently compared to an early or emerging one. The corneal thickness is also a factor, especially for cross-linking. But even if you have a very, very thin cornea, you may not want to impact it. And certainly, Scleral lenses may be better than gas perm lenses at that time. The pattern of evolution, we know that the cone is temporal down and will evolve toward the nasal quadrant and then the superior quadrant. And finally, the budget of the patient will dictate what kind of lenses and what kind of treatment you may afford. As non-surgical options, it's always a good thing to remember that most of the conus can be refracted and they can wear glasses. Their vision is not as precise. Obviously, on a day-to-day basis, we will prefer to have contact lenses to sharpen the images and to make the vision clearer. But evening time, during the weekend, patients may like to have a relief from their contact lenses. So glasses may be a very good option. Or if they are losing a lens, for example, and they wait for the replacement lens a few days, coming from the lab in your office, then they have to see something, and glasses is certainly one very good option. There are ways to refract keratoconus patients efficiently. After that, we'll talk about cross-linking. I already mentioned that. What was popular many years ago, I don't know in your countries, but it's almost over here in North America, but corneal rings were very, very popular. These rings were designed at the first instance to compensate for myopia. It was a competition for laser surgery, and obviously when LASIK came in, that industry of corneal rings just declined, and out of a sudden, a few investigators found that it may be helpful to stretch the cornea and to kind of treat keratoconus, but the experience long term that we had here is certainly not conclusive and certainly not positive on the use of these things. More recently, we some surgeons talk about doing laser surgery, laser intervention on the cornea to remove some tissue from the cone. We will discuss that. And at the end, the very end, is a corneal graft. That was and still in some countries considered number one option. But it shouldn't. It shouldn't really, with the contact lenses that we have now, with cross-linking. Because of the cross-linking and the scleral lenses, the number of corneal grafts dropped by 40% in North America in the last 10 years. So it's very significant, because a graft is not the end of the story. When you graft a patient, a young patient, the average graft will last for 10 to 12 years. So be prepared to have multiple grafts done on that particular patient, and certainly it's not a good thing, because always of the time, with each graft, you may have rejection, you may have issues, you may have complication, and still corneal graft or grafted cornea is an irregular surface that will need contact lenses. You cannot really refract a corneal graft efficiently, certainly not as a keratoconus can do, but corneal graft is still, visually speaking, a problem. So you will need. So if you want to eliminate contact lenses from the options, and the corneal graft is certainly not there. Corneal graft is now reserved for the very, very, very thin cornea that are almost broken or collapse, and or when a significant scars is in the middle of the visual axis and limit the vision. So these are the two main reasons for corneal graft. There's no real logical reason otherwise to perform a corneal graft nowadays. Refracting keratoconus, as I said, it's very doable. So retinoscopy, again, habitually I start with a lot of minus. I start with the -10 lens. So I have a very good positive reflex. So I add convex power. I go meridian by meridian. If you concentrate in the center of the pupil, it's really feasible to determine your main axis. Even if they are not at 90 degrees apart, they are around that. Habitually, if through the phoropter the image is not that clear, you may just take lens bars or loose lenses to do your retinoscopy, and after that you refine your refraction as you would do with a regular patient. So it's not rare to have prescription like -3, -9, SIL, axis 52, but still these patients see 20/30, 20/40, around that. It's not 20/20, almost never, but 20/30 is better. 20/40 is good. You can drive a car at 20/40 with a pair of glasses. So it's not benign. So you can do that. Certainly, and I had a ton of patients where I did decent refraction, having good visual acuity or decent visual acuity as well. And the optician working with me is always afraid, the patient will never use to that kind of prescription, -3, -9, first glasses ever. Some are presbyopic, and we add, progressive lenses on that, or bifocal lenses on that. Believe me, these patients are so used to see distortion and those things that they will adapt very easily to that kind of prescription, no question. So I never had a problem with that. And it will drive the selection of my lenses. I will mention later on that if you have 20/30 or better with glasses, probably scleral lenses will give you too much high order aberration. It's not the option number one to select to correct for these keratoconus. So let's start with the treatments. I mentioned about cross-linking. For those not familiar with cross-linking, it's we put drops of derived vitamin A proteins. It's called riboflavin. So it's vitamin A proteins that we put in the cornea. There are two ways to do it. We remove the epithelium. That it's the EP-off technique. It's painful, but it doesn't last more than 2-3 days as pain. Very effective because you have 100% penetration of your drops in the stroma. We limit the number of drops and the exposure to UV light after, just to do not alter the endothelium. So it's probably 30 minutes procedure, drop by drop, and then after that we apply ultraviolet light to make these proteins from vitamin A linked with the natural protein of the cornea. So this is why we call that cross-linking. It's linking between vitamin A and proteins from the cornea. And so doing that, the cornea will become stiffer and will resist more to this intraocular pressure, just like a normal cornea would do. So we really stabilize this cone. This is the scenario for any patients under the age of 30, between 30 and 40. Habitually, under 30, I do it upfront because I know that the cone will evolve, no question. A cone that is not evolving under the age of 30 years old, I never saw that. Never saw that. Over 30 years old, it may be the case. So I will wait probably to have to examine 3 months, 6 months, and to see an evolution in the cone. Evolution meaning one diopter at the apex, or visual symptoms, or a change in the astigmatism, refractive astigmatism. If the patient tells me, okay, my vision dropped, I know that the cone evolved, and now it's more present in the visual axis, or the cone becomes steeper. So I don't need anything else to consider cross-linking at that time. So between 30 and 40, we may do the AP-on technique, meaning that we it's more comfortable because we do not remove the epithelial cells. We keep the epithelial cells in place, but with dextran, which is another solution, we just break the intercellular links and the junction between the epithelial cells, so the riboflavin can penetrate into the cornea and exposed to UV light again will produce. So we have a little bit less penetration of the drops in the cornea. So it's not less effective, but it may be less effective. So, but over 30, because the cone is not evolving as much as under the age of 30, it's enough to stabilize the cornea. Under the age of 30, or the younger the patient is, AP-on will not work. See, the cone will still progress. But the beauty of that technique is that we can redo it, in the future. If you did a cross-linking now, and in 6 years from now, you see that, cornea still evolves a bit, you can do it, and you can resume the treatment. So there's no danger for that. So any kind of keratoconus progression, and anyone under the age of 18 should be considered a candidate for cross-linking first before any kind of contact lens is fitted, because it will impact the curvature of the eye. So what is contraindicated? Sorry. Is if the cornea is too thin. So this is why pachymetry and corneal topography is very important before considering those treatments. Any cornea under 400 microns is not a candidate for cross-linking. Why? Because the riboflavin will penetrate too deep in the cornea and will alter the endothelium. So if we expose endothelium that would absorb the riboflavin to UV, UV will destroy the endothelium, and the cornea will no longer be able to remain clear and transparent. So this is why very thin corneas cannot be treated with cross-linking. And but if the cornea is near 400, we can put a soft lens on top of it, which is probably 30-35 microns thick, and after that we can put riboflavin. So part of the riboflavin is absorbed with the contact lens. So we increase the thickness of the cornea, in fact, with the contact lens. Obviously, select a lens that is not UV protected, because UV will not penetrate the cornea, but regular old hydrogel lenses can do the job. If the cornea is steeper than 60 diopters, it will not work as well, because habitually the cornea is thin in the presence of these severe cones, and in the presence of severe scars, the UV will not penetrate the cornea enough, or the light will scatter. The other thing that we have to be aware of is that we limit the extent of the UV exposure, because we don't want to alter the limbal cells, because it would be a disaster. So corneal cross-linking is certainly very good. Is it effective? Yes, it is effective, really, because we see that over 12 months, we gain uncorrected visual acuity, and best corrected visual acuity was better. Why? Because the cornea become flatter. It's not all the time, but in average 1.7 up to 2 diopters of corneal flattening after cross-linking. So this is why it is important to consider cross-linking and to know what will be the effect of this cross-linking on the cornea. Because if the curves of the cone and the cornea is changing, your fitting of contact lenses will be obviously modified, except if you are going with sclerals, because if you put a scleral lens on top of that cornea, the fluid reservoir is there and will compensate for any irregularity of the cornea. So even if the cornea is moving a bit, becoming flatter, then the tear reservoir will just absorb the difference, and your lens fit will not change, and your vision will be the same, because visual acuity in sclerals is driven by the base curve of the lens, not the fluid reservoir. So it's probably the best way to treat patients, cross-linking first sclerals, then after. So this is the gold standard now in keratoconus, and we'll see exceptions, but that's the gold standard habitually. So again, we see this study prove that the steeper keratometric curvature after cross-linking becomes flatter by around 1.5 to 2 diopters. Let's talk about the rings. I'm not a big fan of the rings, as you can imagine. We insert these rings at 75% of the corneal thickness, so we really modify the cornea. Nowadays, the channel is made through the laser, femtosecond laser. It's more precise. Before that, it was by hand, less precise, and we had potential for corneal perforation. Now with the laser, it's more precise, but still, it's not an easy task to do. And the company will determine depending on the profile and the topography, which rings that they will send to you. We have several rings possible. In fact, many options possible. The width of the ring may change. The thickness of the ring may change. You can put a small one on the top and the bigger one on the bottom of the cone, depending. So my experience is that it's not really effective. I reserve it for patients when contact lenses is not an option. Let's imagine Down syndrome patients, for example, or neurological syndrome where the patient is not really able to understand how to handle lenses. That's possible, but these may be affected severely by keratoconus. So just to improve their vision and their behavior and to stimulate them in the most appropriate way, vision is important. So we may consider rings for them in order to improve corrected visual acuity with glasses, but that's probably the only exception to the rule, that I do not recommend that technology anymore. And the epithelium over the rings becomes fragile and remains fragile over time. So if you put just a small gas perm lens on top of these corneas, you can get erosions, recurrent erosions over the rings all the time. You can have a corneal perforation. You have migration of the rings over the channel. You can have histiocytes, which are when the white deposit that we see here, not really good to see, and certainly will affect vision and will create the light disturbance and light sensitivity. So the risk-benefit ratio is certainly not in favor of promoting these rings. At least in regular keratoconus patients, you have other options possible. So if you want to put a lens on top of these corneas to restore the vision, it's a little bit more difficult because you have still the cone, you have the ring, so the cornea becomes more irregular, and most of the gas perm lens designed for keratoconus will not fit on that kind of surface. So you have to adapt with irregular cornea designs. Most of the time, it will end up with a piggyback, not only to fit the gas perm lens better, but to protect the epithelium. So I'm really a big fan of piggybacking these gas perm lenses in regular keratoconus and in rings as well, because it's more comfortable first for the patient. Small gas perm lenses hurt, period. Even after 20 years of wear, I refitted tons of keratoconus patients from gas perm to sclerals, and the first thing that they all mention is I thought that I was comfortable with my gas perm lenses, that I didn't feel them, but now that I'm in scleral, I can't tell you that it was completely not comfortable. So Piggyback helps to improve the comfort, the lens centration, and here to protect the epithelium when the rings are in place. And we can adapt the lens sooner, 2-3 weeks post-op, because we protect the epithelium. If you go just with gas perm alone, it may take 2 to 3 months just to have the epithelium stabilize over these rings. Same thing after cross-linking, the epithelium remains fragile for 2 to 3 months if you did an AP off. Sometimes you have some haze in the cornea, and the epithelium is still fragile. So piggyback highly recommended if you use a small gas perm, but in Sclerals, you can refit the patient in a matter of 2 to 3 weeks and no problem. So if you ask a keratoconus patient to wait 3 months to be refitted, they will just say, I can't be out of lenses because I can't see otherwise. So this is why, again, Sclerals may be a very good option. PRK, the laser, they call that topo-guided surgery. It's just to remove up to 50 microns of tissue. It's not a full refractive surgery. It's just to kind of reshape the cornea to make it more regular and to limit the high order aberrations. Again, very variable results. The protocol is not standard, may vary from one center and one country to another one. So I'm not a big fan here, again, from laser to a very thin cornea and a compromised cornea already, especially when I consider that I will refit that patient in scleral lenses. It will not eliminate the need to be fitted in scleral lenses. And if I put a scleral lens, again, the fluid reservoir will compensate for any irregularity on the surface. So no matter what the laser did, I just cancel it with the reservoir. So what's the value? Nothing. And if I want to use a regular gas perm lens designed for keratoconus, because they did laser surgery and they reshaped the cornea, again, the curvature of the lenses will not fit that well on that surface, piggyback and or other design that has to be adapted. But it's complicating my days for sure, to fit regular gas perm on these elements. And they consider laser because of cross-linking. They do both on the same cornea, because just laser will just promote keratoconus, right? It's contraindication if you have a keratoconus to do laser surgery. But if you consider cross-linking, that will stabilize the cone, so you can do the laser first and then to do the cross-linking to just freeze the cornea. Again, some patients do well, some patients don't do that well. It's the exception more than the rule. If I can't fit a contact lens, then I will refer the patients to the ophthalmologist for that kind of procedures. Or if the cone is very advanced and I have difficulty to fit my scleral lenses because I always have a touch on the apex, then I may ask them to remove a little bit of this tissue to help my scleral lens fitting. That's another possibility, another option. Because the risk is that a third of the patient will have no change, which is not good. Again, in 46%, just half of the patient, but a loss of visual acuity in almost 10% of the cases. So it's not really a good outcome. Recent study showed better results, but again, it's not the way to go if you consider scleral lenses. So in scleral lenses, we want really to optimize visual acuity, and we will correct part of the high order aberrations because we compensate for the irregularity of the corneal surface. But you have to remember that the cone is on both surfaces of the cornea. It starts on the posterior surface of the cornea, evolves through the stroma to the anterior surface of the cornea, and then become visible. But if you cancel this anterior surface with your scleral lens, still the posterior surface of the cornea generates a few halos and few high order aberrations that are not compensated. Habitually in a cone, the posterior aberrations at 30% will compensate for the anterior surface aberration. So the overall result is that you have lower high order aberration when you consider just both surfaces of the cornea. So I cancel the anterior surface with my scleral lens. I let my 100% of posterior surface high order aberrations to remain in the visual system. it may impact. This is why some patients, keratoconus patients in scleral lenses, will still complain about, ghosting of the images, shadowing of the images, halos, and they're significant, especially if they have good vision and glasses. This is disturbing for them. Some patients will say to me, "Oh, I'm seeing worse in these scleral lenses compared to my glasses," and that's true because we just remove this natural compensation from the posterior and anterior surface of the cornea. So in those patients, small gas perm lenses or hybrid lenses are preferable because we do not cancel that much the anterior surface aberration. The sag height will also dictate what kind of lenses. If you look at the image here, you have a very, very severe cone with a very thin cornea. To fit a small gas perm on that cornea is a challenge because you'll have to limit your diameter to the top of the cone. So it will be probably a 8.5 millimeter lens, and the lens will pop out. Debris will accumulate under it. It will be not comfortable at all. The lens will decenter where the apex of the cone is, which is lower compared to the visual axis, and then it will generate halos and glare, obviously, because with a reduced diameter lens, you have also a limited optic zone, and if you're not well aligned with the visual axis, you create a lot of disturbance visually speaking. So here, scleral lenses will be preferable, but if you want to vault over that severe cone, you will need a very, very large lens. So it may be a challenge as well. We publish this article in 2018 in the contact lens spectrum. You can have access to it, no charge, through the archives of the contact lens spectrum website. And we explain how to proceed with the algorithm with the lenses we recommend. So obviously my option one, as I mentioned already, is Sclerals. Because of the comfort, we do not touch the cornea, we vault over the cornea. The lens is not moving during the wear. There's limited lens to lid interaction as we have with small gas perm lenses. So it's very efficient way to compensate for keratoconus. Can be fitted shortly after cross-linking. So not a problem. Still some challenges handling for some patients, especially with larger lenses. It may be one difficulty. The cost for some patients may be prohibitive compared to small gas perm lenses. I mentioned the residual high order aberration. If I have very good vision glasses, it may be not the good option for them. If I have very low endothelium cell count, meaning that less than 800 millimeter per square, and that's habitually the case after 5, 6, 7 years of post-graft patients, we know that sterile lenses will generate 2 to 3% edema during the day, which most of the cornea will handle it, quite nicely. But fragile endothelium or fragile corneas like this one here with less than 800 cells per millimeter square will generate significant amount of hypoxia. And especially in corneal grafts, you can generate graft rejection and or opacification of the graft just because of that. And recently we proved that in some cases we can increase the intraocular pressure with fluorescein lenses up to 5 millimeter in average, but some patients will generate plus 10, plus 12 millimeter of mercury and others nothing. So you never know, and you cannot predict. It's depending on the anatomy of the eye and where the lens is landing. The diameter of the lens doesn't matter. Larger lenses and smaller lenses generate exactly. It's the sealing, the tightening of the conjunctiva from the scleral lens wear that alleviate the outflow through the episcleral veins. So it rises the intraocular pressure by 4 or 5 millimeter. The problem is that if you remove the lens and try to evaluate the pressure, you will find a normal pressure because the seal off is now removed and the tightening is now removed. So immediately the outflow will improve and your pressure goes back to normal. But during all wearing hours of sterile lenses, your pressure may be increased. So in patient already treated for glaucoma and or suspect of glaucoma because they have a suspicious nerve head and or they have a big family history of glaucoma, I may refrain to consider scleral. If that's the best tool that I have, despite this thing, I will do it, because, but I will follow my patient very closely for the optic nerve scans and the pressure, and especially the scan. The scan will tell you if you create damage on the long term, because 5 millimeter of mercury will not generate glaucoma. But on a patient already treated, these variation may just increase over time the damage on the optic nerve. So you have to follow that. Hybrids, number two, I know that there are several designs of hybrids around the world. We have here the synergized lenses. They're very effective, very comfortable. When BCVA, best corrected visual acuity, is over 2030 or 2040, habitually, that's my lens to go. Synergizers have their newest version, the ID, where there's no lens to fit on the eye before, no diagnostic lens. You just send your K readings, corneal diameter, and they will design a lens for you. Not available for higher cones or more advanced cones. They have other options for that. The Ultra Health, for example, which is very good lens. In Europe, you have also other types and brands of hybrid lenses. Hybrid is made of gas perm lenses in the center, fusion with a soft skirt. So the lens is almost all the time centered, and make it the fact that the skirt is soft, it makes the lens very comfortable. Less lens to lid interaction with the edges with the gas perm lens, so it's just like a regular soft lens. At the beginning, it's thicker, so lens awareness is expected, but over 2 to 3 days, habitually, it's very, very comfortable. You cannot have front toric options, so if you have residual astigmatism, you have to correct it in glasses. Gas perm and piggyback, I'm going there if I have a very, very severe cornea with scars, neovascularization, for example, because we know that we will generate some hypoxia with scleral lenses. Those that are really happy in gas perm, seeing well, probably I will leave them on that. But most of the time, these are patients fitted 20 years ago, where the fitting technique was to apply a lens that is very flat on the cornea, trying to refrain the cone progression, which is no longer what we are doing, because we know that when you push against the cone with small gas perm, you will generate scars over time, and you will penalize the vision, and you may generate a graft need because of that. So we fit now with what we call the feather's touch, meaning that we are very close, but there are tear exchange under that lens, probably 20, 25 microns, something like that. Not always visible under fluorescein, because fluorescein, you need more than 30, 35 microns to see it. But at the tear, when the patient is blinking, you see that the tears are flowing, so there's no real touch, and we don't consider a real touch as a good fit in any part of the cornea. So in small gas perm, never touch the cornea, and as needed, as I mentioned, piggyback is the option. And we have custom soft lenses also available. I don't use a lot of them because I had highly variable results. Some patients really like them and they see well through these lenses, but most of them, the vision is variable, and they don't see that well compared to other options in the lenses. And multifocal lenses can exist as well in gas perm and Sclerals. So don't forget that keratoconus patients may be presbyopic as well. So this is a busy slide. I apologize for that, but it explains, if you look on the left inside here, the corneal ectasia, it summarizes exactly what I said. So if your vision is better than 20/40, 20/30 in glasses, go with hybrids option 1, Sclerals number 2, Sclerals number piggyback number 2, and custom soft number 3. If your vision is less than 20/40 in glasses, then Sclerals, piggyback, and hybrids. And 1, 2, 3 post graph, you see Sclerals and piggyback again. Piggyback for those with compromised endothelium. If endothelium is okay, Sclerals still. After trauma, if you have a scar, something like that, if it's unilateral monocular, habitually hybrids are more comfortable on just one side compared to Sclerals. If you wear just one Scleral, it may be more challenging. Consider to fit the other eye for refractive purpose. We fit tons of regular cornea patients for refractive purpose because they cannot be comfortable with their soft lenses habitually, or they have residual astigmatism, or they have unstable vision, or they have dry eye. So we fit them in Sclerals, and it's working beautifully. So Sclerals can be fitted on any cornea, not only in irregular cornea. Normal cornea can be that too. And other indices where Gasper may be preferable to scleral lenses. This is coming from Randy Kojima and Pat Caroline from studies they made at Pacific University. They found that if on your elevation map you have less than 350 microns of differences between the highest and the lowest peak of that cornea, then if the difference is less than 350, you have better chances to have a successful fit in gas perm lenses compared to scleral. If you are over, like in this case here, the highest point is 170, the lowest point is 175. You have a difference of 375. Then you are over 350. Then scleral lenses will be preferable. Let's talk about scleral lenses for those not so familiar with that lens. 4 elements to consider. First, diameter. There you have options of smaller sclerals with 15.5, 16 millimeter of diameter, and larger diameter lenses with 17, 18, 19, up to 20 millimeter. And the larger is habitually it's reserved to treat eye diseases, ocular surface disease. For keratoconus and for refractive purpose, habitually we deal with between 15 and 16 millimeter because it's easier to handle for patient, and we vault efficiently the cornea and the limbus. So the central vault is very important. We have to limit that vault to 250, 300 microns at insertion to alleviate hypoxic stress on the cornea, and you will lose that fluid over the day. It's natural process. While the lens is sinking on the conjunctiva, you will lose around 100 microns, and the bare minimum to have at the end of the day is around 100 microns. So if you start at 250, you lose 100, you will keep 150 at the end of the day. It's very, very safe. Limbal vault, no touch over the limbus, not because we will impact limbal cells, as some authors may say, but it's a mistake, not true. But you will, if you touch the limbus because your diameter is too small, then you will generate a mechanical stress and you will generate neovascularization. So this is why to alleviate limbal vault. So we have to vault entirely the cornea and to land on the conjunctiva to have a very nice conjunctival support. And we know that conjunctiva is highly irregular. So this is where the art and the science meet together. We may have 300, 400 microns differences between the peak and the toricity of the cornea has nothing to do with the toricity of the conjunctiva. So you have to most of the time adjust with toric peripheral curves and or to prescribe quadrant specific curves. So these are these very big lenses with a central zone, optic zone up to 9 millimeter, which is way larger compared to any kind of gas perm lenses. And even if the lens is decentered a bit, you will get better vision out of that compared to any kind of small gas perm lenses that will be decentered on that cornea. And then you have a peripheral zone, a reverse curve that will vault over the limbus. And then you have multiple peripheries just to adjust and to land on the conjunctiva. As I said, if you are too close to the limbus, you will impact mechanic lens. It will not be comfortable for the patient. So you have to have a lens that is fitted to over vault the cornea by at least 1.5 millimeter over the limbal area. And obviously the corneal diameter will dictate you how large your lens must be. If you treat ocular condition larger compared to smaller, if you have a pellucid marginal type of keratoconus, the ectasia is very low in the cornea. So if you want to vault over it, you have to go with a larger lens, probably 17 millimeter instead of 15 at that time. And other issues will dictate the midday fogging, the compression. So the larger the lens is, the more complication you may have, and the more adjustment you have to do with all the curves and all the stuff. So habitually, we will evaluate the central vault, as I mentioned, through the slit lamp. At insertion, we want to have a 1-to-1 ratio, meaning that the tear layer under the lens is equal in thickness compared to the thickness of the lens itself. At the end of the day, or after 30 minutes, 40 minutes, uh, when the lens is stabilized, then we want to have a 3/4 ratio up to 1 of thickness, so a limited, reservoir thickness compared to the vault. And this is what we have as the as the slit lamp image. You have here the thickness of the lens, and then you have the tear reservoir. Habitually, when we do a diagnostic lens fitting, we put fluorescein in the bowl, so it's very easy under the slit lamp to see that. And as you see here, it's 1-to-1 ratio, so we have similar thickness. This is what we want, and we have to look from top to bottom of the cornea, make sure that you have, vaulting over all the surface, because if the lens is decenter, you may have a touch on the superior part. Be aware of that. You can measure the thickness of the tear reservoir through the slit lamp here, 176. That would be my ideal fit at the end of the day or after 4 hours of wear, because it's more difficult to see through slit lamp when the patient is coming in for follow-up at the end of the day, because we can't put fluorescein from the outside. It will take hours just to penetrate in the reservoir, and we cannot remove the lens and put it back with fluorescein because it's no longer a lens worn for 4 to 5 hours, where we have to evaluate if we have a touch over the limbus or the cornea. But here, the OCT is certainly helping to determine what is the optimal profile. And you have in an optimal profile here. Here you see that it's thicker. My reservoir is thicker compared to the lens. So it's not appropriate. It will generate hypoxic stress, and it will make the lens to decenter. It will not impact vision. Vision is not impacted by this thickness, but the comfort over time, because of the hypoxic stress, may be impacted. As I said, to look on the top of this lens on the superior cornea, is we have a very good vault here, but we have a touch here because the lens is highly decentered. The larger the lens is, more decentration you will have. Smaller lenses, 14, 5, 15 millimeter, almost never decenter. So this is another advantage of lower lenses. You will lose 100 microns, as I said. It will take 4 hours for the lens to stabilize on the conjunctiva, but after 30 minutes, you lost already 50% of what you will lose in the entire day. So you can really evaluate. So you put the scleral lens on the eye, and you will evaluate it after 30 minutes just to make sure that you have, and what you lost already, then multiply by 2, and it will dictate, at that time, I would expect to have around 200, 225 microns of vaulting centrally, and 50 to 75 over the limbus. And I'm sure that at the end of the day, I will not touch. But you may be surprised. Some conjunctiva are very, very smooth, and over 6 months, a year, 2 years, the lens is just sliding, and the perfect lens that you fitted 2 years ago, patient is back, and boom, you see a touch. Maybe sometimes it happens, but you just revisit your fit at that time, and it's okay. Fluorescence over the limbus obviously tells you that you do not touch. In any case you have a doubt, let the patient go, remove the lens at the follow-up, stain the cornea. If you see staining over the limbus, that means that you touched at a given point, and certainly not acceptable. You don't want to have excessive vault over the limbus, because it's an open door for debris to enter and to accumulate in the reservoir. We call that midday fogging, and it may alter the vision. It may reduce the vision. So the patient has to remove the lens, refresh the fluid in the reservoir, and put the sterile lens back. Again, if we have shallower clearance over the limbus, then we will have a touch, and we will do mechanical stress. OCT again here may help, because we can evaluate over the limbus. If we have a vault, we can really measure with the caliper how many microns we have. So it aids our days and here's our fitting. Compression, we want to alleviate this blanching here, because we compress the blood vessels, not comfortable for the patient, and will have a rebound redness when the lens is removed. So we want to have this very nice white and clear conjunctiva. Despite the fact that it's a little light compression here, we would want to remove it. So we want to land very nicely, optimal like this one here. If the edge is lifting, obviously discomfort, lens to lid interaction will be there, and you'll have comfort issues. So you can modify just that curve if the remaining of the fitting is good. Ask your lab, work with the consultants with your lab. These are your best friends, right? Talk to the consultants, and you'll get the optimum fitting. Without a profiler, you don't know really how toric the conjunctiva is. And over 15 millimeter of cord, we know that this astigmatism, conjunctival astigmatism, will increase significantly. 75% of the eyes will show a conjunctival toricity that is not symmetrical, meaning that they are not 90 degrees apart, just like the cornea. So in keratoconus or not keratoconus patients. So this mounts and valleys will dictate how the lens will stabilize and will land. And you may have compression on the nasal temporal quadrant, for example, and nothing on the superior and inferior. So this is why you have to deal with toric peripheries and quadrant-specific toric peripheries. Again, many manufacturers will tell you how to do it, and you can have their webinar formation and education about their lenses, and they will help you. So over refraction, as it is for regular contact lenses, to end up with the final product. For small gas perm lenses, for frost and nipple cones, we can use spheric regular lenses. Larger lenses are preferred for comfort and centration. We deal with 9.8 to 10.8 millimeter lenses. When you reach the low to moderate cone level, you need specialty designs. The regular gas perm lenses no longer are the way to go, because you will create a lot of 3 and 9 o'clock staining, and it will create a lot of physiological impact. You have to fit regular gas perm lenses very flat in order to be stable on these low to moderate cones. So this is why gas perm designed for keratoconus, and there are many designs around the world, are preferable. And as the cone will evolve, you will reduce your diameter. So here it's 9.5 to 10.2. For advanced cones, you may be as small as 8.5 with a lot of problems, decentration, optical axis, all that stuff. Halos, they are reduced VA. So most of the time, piggyback is the way to go, because if you use we'll see that, but if you use a convex carrier plus 0.75 or plus 2 or plus 3 soft lens, then it, because of the center of gravity of that lens is anterior to compared to the cornea, you generate a better centration of the gas perm lens, and it's one way to improve your gas perm fitting in keratoconus patient. As a first selection, on average, again, follow the fitting guide of your the particular lens you are dealing with. But in general, we go with 2 diameters flatter than the steepest K, or 0.2 steeper than the average K. And depending on the diameter, again, with larger diameter, we will go a little bit flatter than that. It's all about the sag of the lens over the lens. Here, we want to have a feathers touch, 3-point touch, but feathers touch, meaning that, you know, fluorescent or tears is exchanged under that surface. There's no real true touch, but certainly it's very close to the cornea, just to make sure that the lens is stabilized. From topographer, you can more and more, you have software helping you to design and to reproduce fluorescent patterns, so you can adjust every parameters of the lens that is there. So the ideal fit of a keratoconus patient is just like this one here. Good tear exchange on both sides, nasal temporal, to alleviate 3 and 9 o'clock staining. The lens is well centered. You have this 3-point touch here, 1, 2, and 3-point touch here. So this is what we want. But if the patient is blinking, we will see some fluo going there. Now it's dark because we have less than 30 microns of fluorescence, but it's good. This is what we want. Probably a little bit too much tears here. I would probably go with a flatter peripheral systems here, because I have a little bit too much tear exchange, but and either steeper edge lift or flatter curves here, depending on what you want. This is a feathers touch. You see a cone, obviously, with the vault stria, which are really characteristic of the cone. Under white light, you may see that it's, you know, fainted fluorescent, but when the patient will blink, you will see that, you know, there's no true touch. That's one thing that we want to have. A true touch like this one is to alleviate, because it will generate, you know, whirl-like pattern staining, and over time it will generate scars. We don't want to have this. Again, peripheral curves are too flat here, too much keratin, and a lift off. You may see bubbles around this edge here when the patient is blinking, so you know the lens will be highly discomfortable, because lens to lid interaction is very high. So you correct that with specific design like ACT from rose K lenses. You can modify by quadrant the peripheral curves to make it a little bit closer to the ocular surface without impacting the rest of the lens. So again, work with your lab, work with your consultant. If you go with a piggyback, which is most of the time with small gas perm lenses, habitually I'm starting with a plus 0.75, but the higher the convex is, the better the centration will be. Sometimes I use a plus 4 or plus 5. I'm not inducing a plus 4 correction in that field. It's just 25% of the lens carrier power that is transmitted. If I use a plus 1, I will impact by a quarter of diameter my lens power. So if I'm already fitted the gas perm lens, I have to modify my gas perm lens power in order to accommodate for my piggyback. At 0.75, I believe there's no visual impact on that. Let's talk about hybrids. A few words. Again, you have a gas perm that is aligned with the cornea. Habitually, it's really following the cornea with regular hybrids. For cone, if you have a specific design for the cone, you may have a vault of 150 to 250 microns over that. Over the junction, you will have some fluorescein accumulating, and obviously the skirt will land nicely. This is the type of fluorescein pattern you may have. Here, you don't have to wait more than a few minutes to evaluate this. And obviously, we expect a movement on the eye similar to a regular soft lens. So this is what we want. And finally, the custom soft lenses. I'm working with the Keratoconus IC. There are several other brands around the world. This is coming from the UK. We have a large optic zone of 8 millimeter with everything that is modifiable, customizable. Again, the fitting guide tells you what kind of lens and what curve, what diameter to do, to go to, depending on the profile of the cornea. You have 4 quadrants, and you can adapt your peripheries according to what you see on the eye. If you have a fluting, meaning kind of a space between the skirt of the lens and the conjunctival, you go with steeper peripheries, and you can do bi-quadrant. This is the beauty of these things. But in practice, the vision is always, most of the time, always unstable, and I have very few patients who really are happy with that kind of lens. And you have to have the lens that is moving a lot, because that's why the vision is not so stable, because these are very, very thick, soft lenses to compensate for the corneal irregularity with hydrogel material. That means that you have no permeability to oxygen through the lens. So the cornea will suffocate if you have a tight lens on the cornea. So you have to fit loose in order to have a lot of tear exchange, in order to provide oxygen to the cornea. But fitting a loose lens, the lens is moving a lot. And if you have -3 sill on that lens and the lens is working like this, then you will not have a good vision and a stable. Limited. These lenses are limited in usage. This is my last resort. If patient cannot tolerate gas perm, piggyback, cannot handle several lenses, and not seeing well in glasses, then that's it. Soft lenses, custom soft lenses may play a role then. And that was the presentation. So we have a few minutes for questions.
Thank you so much, Dr. Langis, for that very comprehensive presentation. I think you really covered, I guess, almost 99% of options available for keratoconus fitting, all the lenses, and starting from the basics to the advanced lenses which are available. And so the first question says, I think probably you did mention something about laser in helping patients with keratoconus. So would you want to?
Yeah, laser is used just in conjunction with cross-linking. Laser alone is prohibited. It's contraindicated when you have a cone, because you will make the cornea thinner and the cone will just evolve. So when you consider cross-linking, some surgeons will try to compensate the surface irregularity, and most especially the high order aberrations, with topo-guided laser, meaning that they will remove a few tissue here and there in order to reduce the overall high order aberration and or to reduce the irregular astigmatism. Again, if you correct with regular gas perm lenses, meaning keratoconus gas perm lenses, these designs are made for keratoconus, not altered keratoconus with laser. So the fit may not be that well, except if you do piggyback again. It may be more forgiving, but scleral lenses, we will just cancel the effect of the laser because the reservoir will just compensate for the anterior surface. So there's no value to do laser when you consider scleral lenses. So these are limited for me in patients where we consider glasses after cross-linking. Then yes, it may improve their vision.
All right. Okay. And according to your experience, have you found out any changes or progression of keratoconus post-COVID? Just somebody is
No,
asking that.
no,
No.
COVID has no impact really. Um, it was documented that COVID virus may be found in tears, but there's no report of transmission of the virus or the infection through tears, meaning that if I touch my eye and I touch your eyes with my tears, that would be infected. You will never develop COVID, right? The charge of the virus, the viral charge is not enough to generate the disease in the other individual. It may create conjunctivitis though, and then obviously the contact lens wear may be contraindicated during the conjunctivis period of time. And it's a viral conjunctivitis, so it takes a week, 10 days, and it's over after that.
Okay. Right. And we do understand that most of keratoconus patient would have an underlying pathology of dryness as well. So if let's say the patient comes in with a very severe kind of a dry eye symptom, uh, is there any to-go lens which you would prefer over the others?
That's a very good question. Thank you for asking that. We have two things here. We have a very dry eye condition and keratoconus, and both can be keratoconus may be a consequence of a eye dryness because eye dryness generate eye rubbing, and we know that the number one triggering factor for keratoconus is eye rubbing. So if you have a patient with a soft cornea or emerging cone, please ask them to never, never, never rub their eyes because rubbing the eye will just promote keratoconus, even after cross-linking. So I would treat dry eye as a dry eye patient, meaning that, meibomian gland dystrophy, hot packs, massage, compresses, artificial tears, if I need cortisone, cyclosporin, everything that is needed to treat the dry eye, to the exception that when I recommend massage of the lids, I will make sure that the pressure on the eye is not that high to do not impact the keratoconus. Same thing for the mask. Don't let the mask too long on the cornea because the cornea, because of the heat, will become softer. So it's not a really good thing for keratoconus patients. So I manage my lid hygiene according to that, and then I consider contact lenses. In that case, scleral lenses are in my mind the best option because the tear reservoir will compensate for the eye dryness, and the eye will remain wet during all the day. So, and the more severe the eye dryness is, the larger the lens will be to cover most of the ocular surface, and the patient will be comfortable. So medication plus scleral lenses are probably the way to go with that kind of patient here.
All right. Yeah, great. So I think treating the underlying cause of dryness, as you were saying, doing lid massage and compresses would be definitely a good.
Because just lenses will not take care of that patient properly.
That's right. Okay. And a couple of more questions which have popped up. Would there be any specific cases where you would refrain from fitting any lenses straight away? Anything in terms of corneal conditions where you would not fit RGP, sclerals, or piggybacks, hybrids of custom soft lens?
Yeah, as I mentioned a bit, there are very, very few patients for which I do not recommend contact lenses is when they are not able to handle or to take care of their lenses. Some patients with handicaps or neurological disorders are not really able to manage their lenses, and they have no one at home that can help them. So these are the patients where I will just prescribe glasses. Otherwise, I always find a way to correct their vision with glasses, or no, with contact lenses, not glasses. It's either GP or Sclerals or piggyback or hybrid or custom stuff. Graft rejection, not really. As I mentioned, if I have a limited number of cells in the endothelium, Sclerals may not be the appropriate option because of the hypoxic stress. Then gas perm and piggyback are certainly considered number one option. Hybrids less, because habitually the junction between the rigid and the soft lies immediately where the stitches are at the junction of the graft and the host, and we may generate at this junction, because actually it's more elevated, we may generate mechanical stress that promote neovascularization, and neovascularization may promote graft rejection. So I will refrain of hybrid lenses, but small gas perm, piggyback, both of them with high decay material. Piggyback is easy. You put your silicone hydrogel lens, your preferred daily disposable silicone hydrogel lens plus 0.75 on the cornea, and that's it. You're done. You have a piggyback without impacting really the fit of your gas perm lens that you already have. So that would be my suggestion.
All right. Okay. And just looking at the next question, I think you did have a slide on this, and I think you gave us a flow chart on
Yes.
what the VA, and probably we can take that as a guide if that's okay, right?
Yeah, Sclerals first. If vision is less than 20/40, 20/40 are better. Hybrids or gas perm lenses, and hybrids preferred to gas perm for low to moderate cones. Moderate to severe cones, it's gas perm lenses for those patients, but 90% of the time it's Sclerals as my first option.
Okay, great. And you did mention that you are probably seeing keratoconus for younger patients these days. Any particular reason you think this is happening? Any?
Yes. Eye rubbing, period. Eye rubbing coming from two things in young patients. The use of electronic devices first will generate dry eye because they blink less. And we see those meibomian gland dysfunction on patients of 15, 20 years old now. Their lids are really comparable to an old lady of 75 years old because they do not blink, they do not stimulate their meibomian gland, their meibomian gland just collapse, and they have dry eye because of that. And because they have dry eye, they rub their eyes. And we have more allergy compared to what we had 20 years ago. 70% of the population is allergic to something. In some areas, pollution plays a big role as well, the particles in the air. So again, it's really rude on the ocular surface, making patients to rub their eyes, and eye rubbing is dictating, is triggering keratoconus. Not on everyone, but in a lot of patients. Some author said that we have all the genes to develop keratoconus. There are 3 genes associated with keratoconus already found, but we have all of them. We share these genes on every human being has a potential to develop keratoconus. In some countries, like the North African countries, for example, the prevalence is 1 out of 300 in the population. Why? Because it's sandy, it's hot, dry eye disease is everywhere. They're exposed heavily to UV without protection, and UV generate, free radicals in the cornea. Free radicals destroy the natural proteins of the cornea, and you make the cornea softer because of that. That these are all reasons why we see that on young patients.
All right, great. Thank you so much for your input. And let's just take one last question before we can end for today. We did mention that the cornea undergoes some amount of flattening post cross-linking procedures. So do you think prescribing glasses would be a best option before probably you start fitting them with lenses? As you mentioned, 3 to 6 months is the time start putting them with lenses, and it would
No,
be economic.
I think that economically speaking, scleral lenses are better because if you consider that flattening of the cornea is not predictable first, and it will occur on a long-term basis. Between it takes 12 to 18 months just to stabilize the cornea after cross-linking. So you may lose 2 diopters. If you lose 2 diopters, your gas perm fitting will not be okay anymore. Your refraction will change. So your glasses will have to be changed periodically every 3 months or every 4 months because the cornea curve is changing. With scleral lenses, all of these changes on the cornea will be absorbed by the reservoir. And because you keep the same base curve, you keep the same power, the lens and the vision will still be 100% perfect. So really, after cross-linking, the most economical and the most rational way to go is to go with scleral lenses.
All right. Okay. I think with that, thank you so much, Dr. Langis, for taking the session for us and answering the questions and sharing your expertise.
Thank you. You have my email. So if there are some remaining questions of people want to reach me, share my contacts, no problem.
Thank you so much.
Thank you. Thank you. Have a nice day or a nice evening.
Yeah. So please do join us tomorrow. It's at the same time as of today. And we are going to go through some cases of the anterior segment and ocular surface disease. So I hope to see you all again tomorrow. Until then, take care, be safe, and bye-bye. Have a good evening.